Okay, welcome everybody. Welcome to this very special webinar sponsored by Servier, to whom we are deeply grateful, and hosted by EMG. I'm your moderator, Dr. Jonathan Sackier, and I'm privileged and humbled to be here today. In Love in the Time of Cholera, Gabriel Garcia Marquez's landmark work, affairs of the heart during a pandemic were the topic. Today, affairs of the heart during the COVID-19 pandemic will be our focus, but affairs of a very different kind, cardiovascular disease. If we have time at the end, we shall endeavor to answer your questions, which you can post in the chat window. And if we don't have time, you can post them at the website. To discuss this subject, we have a fascinating panel. 2 patients, a gentleman who has dedicated his life to patient advocacy, and of course, an eminent physician. And to be truly cosmopolitan, in addition to this Englishman, we have an Italian, an Irishman, a German, and a Dutch lady. So let's start there. Patricia Vlasman was born with hypertrophic cardiomyopathy in 1971. With heart failure, and after many cardioversions and ablations, she eventually underwent a successful heart transplant in 2018. She's documented her journey and is an international patient advocate. I hope I don't slaughter this, but groeten, Patricia.
Hello, Jonathan.
And moving on, we have Winfried Klausnitzer. He had a silent heart attack in 1990 and gradually became shorter of breath. Several years and several diagnoses later, he was diagnosed with heart failure in 2014. Guten Tag, Herr Klausnitzer.
Hello, Jonathan. Hello to everybody.
And we have Neil Johnson, who's dedicated most of his adult life to patient advocacy. He's chief executive of CRI, the charming Gaelic word for heart. And this organization serves cardiac and stroke patients. He and our 2 patients are involved in promoting global heart health. Fulcha, Neil.
Thank you, Jonathan.
And I wish I understood what you said.
Yeah, I know, you had the clue.
I'm guessing it's something
I knew
nice.
You hadn't a clue, yeah.
And I'm trying. My Gaelic is limited to what Google
No, it's perfect,
provides.
absolutely perfect.
And last but not least, we have Professor Salvatore di Somma. He's a distinguished professor of medicine at Rome's Sapienza University. Sapienza, of course, means knowledge, where he has several major responsibilities. And he's our expert opinion for today. Professori, saluti.
Ciao, thank you everyone for the kind invitation. It's a pleasure to be with you today.
So, Patricia, let's start with you. You were dealing with heart issues throughout your life, yet you went to university and have held important jobs in the Ministry of Justice and the police. What sort of symptoms have you suffered?
Well, Jonathan, at first, when I was a teenager, I could handle the disease pretty well. I couldn't do sport classes, and on Friday night partying, I was totally worn out the weekend, but I could live normally. My symptoms became severe after pregnancy. Then I had shortness of breath, fluid retention, and arrhythmias.
So you mentioned after pregnancy, right? But you were advised not to have children at the time, and I believe your son is now 18.
Yes, that's correct. So I'm an old lady. You have that right.
Hardly.
Well, in my time, I got the diagnosis of hypertrophic cardiomyopathy when I was 13 years old. So it's really a long time ago. At that point, there weren't that much studies about this disease. So yes, they advised me not to get pregnant. And also, it was a real issue because, it's HCM is you can inherit it. You can give 50% chance that you give it to your child. So that weighed heavy on me too.
Sure.
So
was there at any point, Patricia, where doctors were saying that you should not go ahead with this pregnancy?
No.
Okay.
We decided together with the hospital because I got pregnant through anti-conception. It was not the plan that I was supposed to be pregnant. So, but when I was, then we sit down with all the doctors and we decided, okay, well, let's go on with it and let's monitor it good and properly and just see what happens.
And your son was tested and had not inherited the condition.
Thank God.
Yeah, absolutely. And just for the benefit of non-medics, I'm going to throw to you, Professor. First of all, if you could tell the folks listening who may not know what hypertrophic cardiomyopathy is. And secondly, how typical is Patricia's journey, and with modern drugs and treatments, how often can patients nowadays lead the sort of fulfilling life that she's led?
First of all, hypertrophic cardiomyopathy is a very congenital and hereditary heart disease characterized by the increase of the mass of the muscle. So the left ventricular chamber is very much reduced. And you know, apparently the heart is not having severe symptoms, but there is a risk of sudden death. And also there is a risk of bad life. So in these patients, transplantation is always the solution. So this is a disease, the congenital hereditary disease, where the transplant is the solution. By the way, coming back of the Patricia situation, today, thanks to the many progressive innovations that have been done in the pharmaceutical components and technology, patients with heart failure, any kind of heart failure, can have a good quality of life. And this is important, so patients can travel, they can make exercise, they can dance, they can do everything, even having a child, so having a pregnancy. What is important to recommend that, like Patricia did in her experience, is these people make a very carefully, strictly risk stratification at the beginning, right? So it's important to make a risk stratification, the opportunity for the woman, not any kind of a consequence like such as eclampsia or pulmonary embolism. On the other side, you have to make sure that the newborn should be safe. And in this sense, closely monitoring these subject with frequent EKG just to detect arrhythmias, or NT-proBNP to monitoring the left ventricular function is crucial. So I think at the end of the day, thanks to the big progress we have done in this field, people with heart failure can have, let's say, a quite normal life.
Yeah, well, wonderful, and it's apparent from everything Patricia does that she embraces life with passion and commitment, as we all should, because I'm sure you'd agree, Professor, every single one of us is at risk of sudden death. And yeah. It's always struck me that that's an unnecessary qualifier. All death is sudden. Winfried, when did you first notice symptoms, and what were they?
My symptoms started approximately 12 years before I got my final diagnosis. The symptoms are very similar to Patricia ones, were tiredness, decreased performance, insomnia, fast heartbeat, dizziness, and shortness of breath.
And those can represent all sorts of things. And you were initially misdiagnosed as having chronic obstructive pulmonary disease, bronchitis, and other issues. What led you to persevere? Because sometimes people just accept what doctors tell them, but you didn't. You just kept going and sought other medical opinions.
Yeah, it's a simple reason. If new drugs and changed doctors do not improve anything, the self-preservation forces us to do so. Ultimately, however, a life-threatening situation let me go to the emergency department and resulted in the final diagnosis.
Okay. Well, we're very grateful that you did persevere and are now very, very involved in advocacy, which we'll come on to. Professor, Winfried's first heart attack was asymptomatic. How often does that happen? And conversely, what percentage of first heart attacks are, well, the first symptom of which is 6 feet of unwanted or 2 meters of unwanted real estate in a pine coffin?
Yeah, this is a really important issue because many of patients with heart failure at the beginning, they have no specific signs or symptoms, right? They just can have fatigue or let's say insomnia, like you say, that are not specific. And also even having sometimes coronary artery disease are not specific. You can have a really not very symptomatic signs that so you are not going to the doctor to visit doctor. And even in the phase where you are going to be seen by the doctor, since the shortness of breath is a situation that is common to many other diseases, there is really need to increase the skills of the patients and of doctor to better me awareness and take out the number of patients that are in the early phase so that we can have a better early diagnosis that for any cardiovascular disease is very important to be done as soon as possible. So I think the story of Winfried is quite common, unfortunately. And just to answer the second question you raised, yes, acute coronary syndrome is per se a situation where you are going to impact the left ventricular, the heart pump, right? Because you are losing myocyte, you are losing cells, you are losing mass of the muscles. So acute coronary syndrome per se is heart failure. But it's, of course, the most important reason. So high percentage of people that suffer for acute myocardial infarction, as a consequence, they can have heart failure. But there are also other important diseases that can lead to heart failure, such as diabetes, hypertension, valvular disease, cardiomyopathy, such as the one Patricia has, hypertrophic or dilated, post-myocarditis, post-cancer treatment. So there are a lot of needs to check in the early phase, many situations where you can have heart failure without many symptoms.
So, in fact, it's great that you said that because I've got a follow-on question. Winfried ended up with heart failure as a result of muscle damage from his myocardial infarction, his heart attack. Very different etiology to Patricia. What's the percentage of patients who have an MI, a heart attack, who then develop heart failure? And you've mentioned diabetes. How does diabetes cause heart failure?
So definitely, you know, if a patient has diabetes, he has already kind of involvement of the muscle. It's diabetes per se. So you have a very reduced vessels because of diabetes, microvascular alteration. And then you have the acute coronary syndrome that goes to close the artery, and then you have a reduction of the function. Of course, first or later, all the patients with coronary artery disease can have heart failure. So the percentage is quite high. And I would say that all the patients with after acute coronary syndrome should be checked for the occurrence of heart failure, because again, they can have no very serious symptoms, no shortness of breath, but heart failure is there. So they should check it for the presence of heart failure.
This is going to be a recurring theme throughout about the need for patients to be educated, the need for patients to talk to their doctors, the need for patients to talk to patients, doctors to doctors. And that perfectly takes us from Italy over the Irish Sea to Neil. And to ask you, Neil, a little bit about advocacy groups like yours. How do you reach out to patients who may be scared, confused, don't know where to go, or do they find you? How does that all work?
So I suppose I'm coming at this from two perspectives. One is, as you mentioned, I'm in Ireland, in the West Coast, involved with an organisation that is working with heart and stroke patients for a large number of years. And then together with Winfried and Patricia, we're working at an international level and creating a global alliance of patients, patient organizations. So to answer your question, by and large, patient organizations interact with patients and carers through a membership or an alliance that forms through various channels. That could be anything from online to events and so forth. So it's very much a two-way street. Patients invariably seek out patient organizations or other patients with similar symptoms. It's an almost instinctive reaction when one gets a diagnosis. So I guess most of the traffic is inward, but the outward traffic from the patient organization is more at the level of education, awareness, and advocacy, I guess.
Well, I certainly know from my practice in surgery, my best source of referrals are my patients. If I've looked after someone and they're content with the service, the professional service I provided, and they tell their friends who need whatever surgical procedure, they'll come see me, which is of course great. And of course nowadays with the internet, it's easy to find information. Of course, there's also a lot of nonsense on the internet, and it's important to filter it. And as such, you've been collaborating with Patricia and Winfried. Can you tell us a little bit about that? So you know about it intellectually. Professor Di Somma knows about it professionally. Winfried and Patricia live with this.
Yeah.
So
there is no. Yeah. So I suppose the first thing would be there is no greater experience than the lived experience. That's the first thing I would say. And to your last point, in the context of access to information, absolutely. And this is one of the big concerns, is that there are patient communities, if you will, evolving and springing up now with the advent of the internet. And many of these are unfortunately not very well controlled or monitored. And that's a concern, I guess, from a patient advocacy point of view, that the wrong information can be made available, or there could be spurious or ulterior motives for certain information being made available. So in the patient community, this is one of the challenges. How do we have these platforms that are moderated and ensuring that we don't have fake news? Because fake news is clearly a big issue.
Yeah, it really is. I mean, do you ever take that on, sort of head to head, when something pops up that is clearly a piece of nonsense? Do you go for it?
Yeah, I think obviously it's difficult to generalize here, but I think by and large, first of all, what's encouraging from our experience in the cardiovascular space is, and we've a survey to support this. In fact, our recent survey supports this, that by and large, most patient organizations are aligned with some medical advisor or medical advisory board. So this is good practice. And in those situations where something reaches the media or popular press, patients immediately react by reaching out to their patient organization or their network. And the question goes out, is this true? Is this true or not? And then by and large, the patient organizations will seek the advice of the experts and communicate that way. That's probably the most common way in which patient organizations communicate to patients. Sometimes, of course, they may have to go and take a more public approach, a more public campaign approach. But again, you're talking about patient organizations that are largely under-resourced, and taking on big media is not really an option. So it's better to go from the ground up rather than trying to take a mass media approach.
So actually, can I ask, for people who are watching today, if they wanted to contribute, make a donation to your organization or others, can they do that? It's a quick plug.
Yeah, absolutely. Well, I think each of us here have our own, with our own organizations. In my case, it's CREI, so it's www.croi.ie. And
exactly
Patricia,
how you'd expect it to be spelled. Yes.
So I think it's the same. Patricia and Winfried are both with their respective patient organizations. So if they want to give a plug for their entities.
Well, I'll tell you what. Let's after this webinar is going to be archived. Let's ensure that those links are put up on the archive, so people who are moved, who may have lost a relative or have a loved one who has cardiovascular disease, to make a donation. Absolutely. So Patricia and Winfried, you're both, as Neil has suggested, involved in advocacy. What would you say the most valuable thing such organizations have brought you personally as patients? I don't want to put you on the spot, but also, isn't it for doctors, patients, and groups like yours to educate patients and not central governments? I may know a little bit about cardiac disease, but I'm not a cardiologist, nor am I a patient who's lived with heart failure. So, Patricia, maybe you go first.
Yes, Jonathan. Being connected with the patient organization gave me the opportunity to learn about my own disease. But also at the same time to educate the doctors about what the patients really need. And I think that's the perfect example that the patient and doctor are having an equal relationship. It's really about a patient-doctor partnership. I think that is the most important thing for me, to educate as well the doctors and the researchers about what really matters to the patients themselves.
Interesting. And Winfried, do you have some thoughts to add?
Yeah, I think as patient, you want to know as much as possible about your disease and how to deal with it. And the group discussions with other patients or invited medical specialists are extremely helpful. Our target is to let the patients manage their own disease. And if you have contacts with other international organizations to exchange information about new forms of treatments and therapy, that's absolutely great.
Jonathan, can I just add something there? Just
of course.
Picking up on what Patricia's just alluded to there, and that's the patient-doctor relationship. And there's a language and a use of language here which is probably useful to address. So, for example, you described us as advocates, and sometimes the medical profession, and it's in various forms across allied healthcare, sometimes there's a sense of being threatened by the notion of an advocate. Now, it depends, of course, on whether your advocacy is about rights or about needs. I think I certainly in the Global Heart Hub, which is this new alliance of patient organizations, we're starting off on the basis of need. We're looking to try and respond to patient need. And then you have a term like expert patients. And sometimes, again, that can be a threatening concept because the doctor, I guess, traditionally is viewed as the expert and, of course, is the expert. But what we're really looking at trying to achieve here is a partnership situation where the doctor is the nurse, the clinician is clearly the expert in the field of medicine, but the patient is the expert in the field of the lived experience. And it's about bringing those two together for optimal benefit for both. I mean, obviously, if you're a doctor, you want to ensure your patient gets well. And if you're a patient, you want to have the best possible outcomes. So I just think it's good to put that out there because it's in the context of the advent of the internet and so forth, this is the new era, if you will. The idea that the patient is really a stakeholder here. Now, COVID has turned this a little bit on its head. We may come to that later in the discussion.
Oh, absolutely, we will.
Yeah, but we were, I believe, moving to a reasonably good place where patients were becoming more engaged, more empowered, and were being viewed by many in healthcare as stakeholders and partners in care. And to me, that's the optimal route forward.
Yeah. I again, from my perspective as a clinician, I 100% concur. Salvatore, do you have something to add for that? And then I have a follow-on question for you.
Absolutely. I think what Winfried, Patricia, Neil said is always very, very true. Let me tell you my personal story, just to address the question how is important to create a patients association for cardiovascular disease. You know, many patients after the acute phase of acute myocardial infarction or acute episode of heart failure, they come back at home and they are in the middle of nothing. They have no support. So they are looking. Of course, they have doctors, they have, but they need to speak each other, right? And also they need to create a kind of a club. So once a patient came to my ward and was discharged, he asked me, please, Professor, I don't want to come back anymore. Because patients with cardiovascular disease, especially heart failure, they are admitted 3-4 times a year for heart failure. They say, could you please help me to avoid the new episode? And I say, you know what? Let's create a patients association that are going to teach the doctors and the new patients how can work together. And now we have really this opportunity to change the paradigm, right? I really appreciate what Patricia said. I learned as so much more the last 5 years in better taking care of my patient that I was trained for 42 years of my personal professional experience. So this is a win-to-win cooperation, like especially for heart failure, is going to impact because patients, as we said before, now it can travel, it can have a woman can have a pregnancy, they can dance, they can. So people need to talk each other, to communicate. And you know, when the patients talk with another patient with heart failure, same disease, they are going to be more interactive and they know more. And also it is important for the caregivers. We should also introduce the fact that this education could include the caregivers, the people that live with the patient.
Yeah, 100%. And there's also the whole mind-body connection that if a patient is happier and more content and living a fuller life, then they're going to be happier, which lower blood pressure, all the things, they're going to be more attentive to their treatment. Absolutely. Now, I told you when we were getting to know one another that I was involved with a cardiac charity that raised money to help treat rare diseases from around the world. And I'm sure you've seen that you can get grants from such associations. From your perspective, what other ways can advocacy groups help you do what you do to help patients live a better life?
It is a very important question, Jonathan, because I think what we are doing in our country is now we are asking the patient to have a direct contact with the governors, you know? So this is very important for direct contact with governors. If I go to the governors as doctors, they don't trust me, right? They are always say, you know, you are looking for your side. But if the patients are really involved in making these people that are making decisions, it's not only about advocacy. They can direct talk with the people. For instance, why you don't provide me this device for free? Why you don't provide this drug for free? So a direct contact from the Patients Association with the institutions is the key reason to have this association, not only for advocacy.
So patient advocacy can actually help take a medical directive and help with a legislative agenda. It's fascinating.
Of course, with the support of doctors, with our support. This is a kind
in the background and quietly, because as you say, it's the same thing over here. It's the same thing in the United States.
Yes.
So it'd be nice, I think, to dig deeper into the stories here. And let's start with you, Patricia. This is a picture of you, Patricia, looking very different to how you look now. Tell us about this photograph.
This photograph was taken one day after my heart transplant, October 28, 2018. I have been waiting for a donor heart for 1 year and 8 months, which is really not that long. Waiting list now in Holland, in the Netherlands, is over 3.5 to 4 years. So I was lucky. And I have had severe heart failure for the last 17 years of my life. So I'm a very blessed woman. And yet again, I could live those 17 years because of the ICDs and the many ablations I underwent. So when you think of heart failure, for me, it's very important that I see when people get this diagnosis, they go on the internet and on Google, and still there is a belief that you have only about 5 years to live, but that's not true. Heart failure is also about living with the proper care and living healthy with maintenance of a little of sports or just to walk outside. And really the passion for life, that really gave me the strength to go on, this passion to go forward. And that kept me mentally healthy, but also physically. So I totally agree with Dr. Di Somma that nowadays we have better medication, we have better devices. And I had transplant, and I'm very lucky. I realize that every single day.
Well, we're very lucky to have you here to tell your story, and I'll make 2 points. The first is anybody who's listening who is not carrying an organ donor card, please consider it. A very dear friend of mine who's quite a successful musician, if people ask him for his autograph, he says, I'll give you my autograph if you'll give me yours on an organ donor card. So I encourage everyone to do that. The second thing is that lovely quote about it's not how many breaths you take in your life, it's how many moments take your breath away. I know I'm slaughtering the quote, but you clearly live your life with passion. Professor, turning back to you. It is, if I'm correct, nearly 53 years since Christian Barnard performed the first heart transplant, and I'm probably going to slaughter the pronunciation, Klausnitzer Hospital in South Africa. How have things changed since then? How often are such operations done? And we can see, Patricia, with what success generally?
Yeah, absolutely. Although, like I said before, there are a lot of new technology and new drugs, still heart transplantation remain the only solution for some patients, especially with cardiomyopathy, such as hypertrophic or dilated. And still there is a really need for some patients to have transplant, because now, thanks to transplant, patients can live very well, like Patricia, for decades. So it is a definitive solution for some patients with heart failure. The limit is that only patients before 65 can have heart failure because of concomitant disease. But the issue is there, unfortunately, for the number in waiting list, there is not enough heart available to be transplanted. Patricia just said that in Holland is almost 3-4 years, in Italy even worse. The only country that is doing very well in this setting is Spain, where there is no reason to ask for taking the heart. They can take without you give the permission. So I think the problem is to, again, the Patients Association work with institutions and governors. Listen, we need donors. So I think that in this setting it's really important to increase the awareness not only of patients, but doctors, but also institutions, to make sure that there is no 4 years to wait. In the meantime, there are alternatives. Now there are left ventricular assistance devices that are taking the bridge from the waiting time from the situation where you need a transplant and you can live with this device that are going to be very good for a long time. So you have, in meantime, to have artificial heart that are being built. So there are some solutions, but still heart transplant remain an important options for patients with cardiomyopathies.
And I know there's work being done on cardiac assist devices and stem cells, and maybe we can come on to that in a little bit. Neil, to come back to you. You've been in this field for more than a quarter of a century. What's changed from your perspective?
Well, I think it wouldn't be an underestimation to say that care and treatment in cardiovascular disease in general has moved in leaps and bounds, particularly in the context of acute coronary syndrome. I mean, I recall in an Irish context, even at the level of the model of getting somebody to hospital and treatment, it was sort of grab and run. And in an Irish context, sometimes that run in an ambulance could take a long time, and very often the patient wouldn't survive the distance. To now, in our country, we have an acute coronary syndrome program. People are from first onset of symptom on the table, stented and out within 90 minutes. It's incredible. So there's been absolutely phenomenal progress. The technologies have significantly, the diagnostic technologies, treatment technologies have significantly enhanced treatments themselves. Even if you look at in areas like, for example, valve disease, and you look at something like TAVI, for example, it's just, it was unimaginable a number of years ago, the idea that you could replace a valve minimally invasively. I mean, it's incredible. But I'd have to say, though, that while there has been a lot of very positive change, and a lot of it has been very much in the acute care sphere, I think there's a huge amount of work still to be done, and particularly in the area of prevention. I think this is the very often the forgotten part of the whole equation.
Well, we're going to come on to that, because that's obviously a major topic. Thank you for that. Winfried, you were diagnosed with heart failure in 2014. And looking at your chronology since then, you've become hugely active in this advocacy space. What drove you to take the steps you did?
At first time, I heard about heart failure at first time when I was informed about my diagnosis. Heart failure is still little known in Germany, and I'm sure in the rest of the world. Although we have more than 3 million patients in Germany, The disease is the most common causes of death. And it's still the disease of old person. And that's definitely not right. The earlier the disease is treated, the higher the life expectancy. Excuse me. I wanted to make the disease better known, and talking with other patient and working with other patient organization and the connections to Patricia, to Neil, Professor Somma, and others gave me courage to push the idea forward.
Well, good on you for doing this, because you're saving lives every bit as much as Professor Somma. I'd like to move on and discuss cardiovascular disease and the implications during the pandemic. Patricia, how's the current situation affected you personally? You're likely taking immunosuppressive medications. Yes, you must have concerns.
Of course, yes. When COVID-19 broke out, everybody was in this huge storm of what is happening. And still, I miss the lack of studies about people who underwent transplant. But indeed, and I like to emphasize, it's not only for me being part of the vulnerable group, but also my husband and child. For example, my son refused to go to school because he was all about, oh my God, when I go to school, maybe I get infected, and then I can make you sick and you'll die after all. You know, so it's not only about the patient, but also about the whole system around the patient.
Yeah, well, clearly you have a very responsible son.
Yeah.
And Winfried, what about you? Have you been seeing your doctors with the same regularity? You must also have some concerns.
I only postponed an appointment in the beginning of March by 2 weeks. I felt safer at home in the beginning of the COVID crisis. After that, I kept all appointments without any interruption. But it's striking that the waiting rooms are less filled than before. And I think the distance rule is only one reason. And I know that the numbers of occupied patient beds in hospitals are still quite low.
Yeah, well, and we're going to address this because there's some nuances going on there. And Professor Somma, I have a number of questions for you. The first, in certain countries, social distancing, I prefer the term physical distancing, has been seen as a political imperative. Italy was very hard hit at the beginning of this. Have you seen any objections to barrier precautions? Are people objecting?
As you know, in Italy, we got a very bad experience in the early phase, because after China, we were the first country where there was a really big impact in number of infected people and the number of deaths. So definitely that was the situation why the government decided to really be very tough to make people at home, and this was really did very well. And at the end of the day, this is because we have a social health system, so this will probably possible because of a special situation. To be honest, Italian people were very, diligent in following the indication in the early phase. Now that the situation is going to be a little bit, improving, I think that people should maintain this concept of just preventive against the virus, because people are now suffering. And I will show later that there is a lot of consequence in, into the psychological behavior of people because of that. But at the end of the day, if you ask me, was it successful? Yes, it was. And how was the people acceptance? Was quite good. But now I think we have not to repeat this experience.
Yeah, you're absolutely right. Have you had patients missing appointments? And what steps are you taking to encourage them to come back to a more regular checkup schedule?
Okay, this is a very good question. I think that this is really something that happened. And then we set up this telemedicine program to control remotely the patients. So this was a way to say, okay, you can stay, continue treatment, or sometimes you can ask people to come safely. Because, this was not only a patient, it was also doctor impact. A lot of doctors and nurse, they died because of this. So it was a concern for the patient and for the doctors. So I think, yeah, many people ask me, can I come to be visited? I say, you know what, just talk each other like we are doing today, right?
Yeah.
Let me see how you feel. Let me see the pills. And sometimes I say, okay, you are safe, just continue. Or sometimes I ask them, please come. So this is the way that we...
But on a video, you can't see if my my jugular venous vein is distended. You can't perhaps see if I'm dyspneic, short of breath, or maybe you can. You're a skilled guy.
No, again, I mean, I can ask you to measure your saturation. I can ask you to measure heart rate. I can ask you to measure blood pressure. And if you are never a regular neck, I can ask you, please close your breath and deeply expire. And you see the so there are something, of course, telemedicine, there is some telemedicine should be not the final solution, but still is an opportunity.
It's a part of it.
But if you...
So there's a specific question I'm burning to ask you. I have read that the number of heart attacks has seemingly dropped during the pandemic. Is this correct, or is there something else going on here? And we've talked about people being scared to go anywhere near the hospital because the virus is lurking. Have heart attacks dropped? And if so, why?
No, this is a fake news. Sorry to say that. At the end of the day, I think this is a nice cartoon that I took out from a 4 days publication. Is one of the most important paper in the cardiovascular field, Circulation, where you can see how cardiologists in the world can go on the waves of COVID-19. You see, you have to fight in the early weeks with the infections, and many people were affected. Then this curve number 2 is what you are referring to, right? That there was a delay in people. So that was not true that the number of heart attacks was diminished. Simply patients were concerned to go to the hospital, and they decided not to go with having a chest pain. And it's terrible because we spent the last 20 years of our expertise to teach people immediately to go to the emergency room in the case of a chest pain, because now we have a PTCA and we can save life as soon as possible. The patient go to the emergency room. So this was because people decide not to go, and I have many patients that actually they delayed to go to the hospital. They even died because of a heart attack, because they were afraid. So I think this is the second wave. So there was a lot of acute cases that decided not to go to the hospital, they died. So the number of acute coronary syndrome was absolutely not reduced, but was, negative results. On the other side, this is also the second negative impact of the COVID-19 in cardiovascular disease. We are waiting for the wave that is not huge, but lasting longer, years. The fact that many people are not going to be visited, not by consultation with doctor, so they are not having the better appropriate treatment as drugs. They are stopping drugs for hypertension, for diabetes, for high cholesterol, anticoagulant, and these are going to be a negative impact of the huge number of chronic disease such as heart failure, chronic ischemic heart disease, vasculopathy, increasing in mortality and morbidity. So this is really a nightmare. So we are not only I like very much this cartoon because it means that there is a lot of consequence, not only of COVID. Last but not least, the mental health consequence. I'm sure that many people can have a lot of depression and anxiety as a consequence. So there is a burden of a disease, especially cardiovascular, that is a consequence of COVID.
Yeah, great points. And thank you for making them. And I think everyone would agree, if you've got any symptom that could be a heart attack, pain, breathlessness, anything, get thee to a hospital quickly, right? Get thee to a hospital quickly. Neil.
Jonathan, if I could just add on to that there. In fact, it's a current campaign of the Global Heart Hub, where the hashtag, it's largely driven social media, is Just Go. And it's for the very reason that Professor Somma has referred to there. We know it to be factually the case across Europe, across the world, that patients decided to put their fear of COVID before the obvious and well-established symptoms of, in most cases, MI. And it's ironic that we're speaking largely about heart failure today, because what actually now is presenting is effectively heart failure as a result of delayed presentation. Yeah,
yeah.
I've heard clinicians say that they're now seeing in some coronary care units conditions that they didn't see, haven't seen for 40 years. And so the message is absolutely critical. We know pretty much what the stereotypical signs and symptoms. There are some obviously variances of this, but if you have symptoms indicative of MI, just go to your.
Well, you know, it's also the case in cancer care. We're seeing delayed cancer diagnosis, and it's really tragic. In fact, I know you've undertaken some survey work, Neil. Perhaps you can tell us a little bit about that and the impact of COVID on your world.
Sure. So the context to this is the Global Heart Hub basically is an attempt to try and bring together the heart patient community across the world insofar as we can possibly do so. This is because, strangely enough, for some reason, the voice in cardiovascular disease doesn't have a platform, unlike most other diseases. If you think of any other disease you care to think of, cancer, MS, CF, you name it, the community, patient community is organized. Not so in cardiovascular disease, and that's what the Global Heart Hub is about. So at the outset of the pandemic, we conducted a survey across 19 countries just to understand how COVID was impacting the patient community and patient organizations. And to be honest, the findings, there's nothing really what you would describe as unexpected here. At patient organization level, you had real challenges around resource challenges, income being down, for example, because lots of these organizations depend on their own fundraising strategies, which are impacted by the uncertainty of COVID. Many had to lose staff. And ironically, then they were being impacted by revenue and staffing challenges at the time when actually they were most needed. So most organizations were reporting contacts from patients and carers, and indeed the general public, increasing by 300% to 400% at a time when their own internal resources were being diminished. A point I had mentioned earlier, and it was good to see this, and it was in the context of fake news and spurious news. If you might recall, in the early stages of COVID, there was a suggestion, for example, that certain types of hypertensive medication were placing certain patients at a higher risk. And of course, that created all sorts of problems at a patient level, to the point that some patients decided they were going to stop taking their medicines. So we were encouraged to discover that, as you would expect, over 80% of patient organizations were being guided in their information by clinical experts in the context of COVID. And that was good to see, because it meant that the information that's out there was reliable and valid. What was interesting was that patient organizations, in speaking with their patient membership, felt that heart patients were not being viewed as urgent for COVID testing. This is in some countries. I thought that was interesting because this was probably the most effective public health message of all time globally. And the message was very clear. If you have underlying cardiovascular conditions, you're in trouble. You've got to stay out of the way of COVID. And so you would have expected, therefore, that not that you'd expect that heart patients would be prioritized per se, but at least there would be some special attention given to the early testing of patients with underlying conditions. As you might have expected, the biggest fears generated by COVID, number one, the fear of being infected, and number two, the fear of going to hospital. And it's interesting that fear of going to hospital is then reflected by what we just discussed, that delayed presentation for MI. And in fairness to patients, I think in a lot of countries, and a lot of countries obviously were caught off guard and didn't necessarily have the immediate capacity and capability to respond to the large numbers of people presenting in hospitals. Hence, and in some countries you had real issues around things like access to protective clothing and so forth. Hence, you saw doctors and nurses becoming infected and dying. So it's perfectly understandable as a patient, if you're reading about doctors and nurses dying in a hospital that you want to go to, they're not going to go there. But I think as the pandemic continued, the medical professional, the medical community, the healthcare community really pulled out all the stops and got to a relatively good place, to where with reasonable confidence you could now say that, you know, best practice protocols are in place in hospitals and pathways, safe pathways are in place. So the message would be very much, again, if you are experiencing symptoms, you know, your risk of dying of a heart attack is 10 times greater than risk of dying from COVID. So don't delay. But other concerns, of course, then were around the fact that many appointments and procedures were postponed. Patients were quite concerned about that, and understandably. There was a reprioritization almost of certain conditions by virtue of the fact that elective procedures were either cancelled or postponed. There were concerns related to medication. I just mentioned one, being hypertensive medication, for example. Unreliable information was a big issue, well, we all know where we saw leaders from different nations speaking about something they really had no clue about, and not being responsible with the information that they were discharging to the general public. And that was a big concern. And then the actual economic impact of this. Everybody knows that we are, if not now, we are definitely going to be paying for this for a considerable period of time. What impact is that going to have on the livelihoods of people? So, as I say, nothing as you would, nothing unusual, I would have thought, in these findings. But I guess it highlighted that the public health messaging absolutely got through to heart patients, and it scared the lives of them.
Yeah. Well, thank you very much for that. We could talk for hours now. I'm very, very conscious of time. We have a limited amount of time, so I'm going to truncate some of this. I'd like to throw to you, Professor. Can you tell us a little bit about the role of telemedicine at this time and give us a brief perspective on this?
Yeah, I mean, as we said just now, there was a lot of concern. So since many patients COVID positive, 50% was not needed to be hospitalized, we set up in our institution this telemedicine program. Twice a day, patients were connected with the central center with nurses support and having consultation. And this was an experience that I think we should take as a model in the future. So within many night disasters that the COVID did, probably this is an opportunity. So in the future, we can establish a telemedicine program for heart failure patients or heart disease. If you give me next slides, I will show you that thanks to this technology, now you can even send from a house for small hospital information like EKG, ultrasound, biomarkers such as NT-proBNP, and you can reduce the concern of patients to go to the hospital and office, and you can manage some patients. I think this will be something that as a patients association within doctors and governors, we should evaluate in the right way, because this is not the all case solution, right? But it's a solution we can take in mind in order to, in the future to manage some patients and bring the hospital in the territory. Because at the end of the day, situation like chronic heart failure is a situation where the patients need every day some support, and this should be done by telemedicine program. So I think this is an experience that we should take together, patient advocacy, governors and doctors, to push to in the right way, even to write down guidelines on how to use telemedicine, heart failure or other disease.
Yeah, basically COVID has accelerated the adoption of technology. Can I also ask you to briefly comment on how medicines and technology have improved in heart failure? You hinted at it earlier, but it really is, there have been some dramatic changes, right?
Absolutely. I think the device increased. I already mentioned the left ventricular assistance device, but we have to mention about the defibrillator like the one Patricia got. There is a lot of possibility to avoid sudden death, controlling ventricular arrhythmias. And there are also ablation for atrial fibrillation. So there are a lot of arrhythmias that now, thanks to the system of technology, we can control and manage easily. And also, I think we should think about now non-invasive valvuloplasty, such as for mitral alteration or aortic, already Neil mentioned TAVI. So there is really a big possibility for patients to heart failure to have an approach having some technology that can save their life. So I think this is very important, and certify how much effort we did in the past to better increase the quality of life. That is what matters, right? More about the daily life.
And I think I do want to make the point. I'm going to throw to each of you and ask you one final question in a second, but just to make the point, which I know we all agree with, prevention's better than cure. People need to watch their weight. They need to exercise. I have a simple rule. I only exercise on the days I eat. Don't smoke cigarettes, pipes, cigars, don't chew tobacco. Check your lipids. Go see someone as clever as Dr. Salvatore di Somma, who will check your lipids, your blood pressure, look in the back of your eye, and listen to people like Neil, Winfried, and Patricia, because their advocacy is a game changer. So first of all, I'm going to ask you, Salvatore, what's the one big change that you think that we're going to see in the next 10 years? Is it going to be stem cells? Is it going to be gene therapy? What's coming down the pike?
I think that, Jonathan, beside these important improving technologies that are all the ones you mentioned, I think the patient's awareness about prevention,
Great.
how to make a different approach in daily life will be contributing a lot in increased mortality and rehospitalization for these patients. So I think beside technology, patients' awareness contribution, like the one what we are doing with the Neil, Winfried, and Patricia, is a solution. And let me add again, telemedicine program. It is not the only solution. But
you were only allowed one, but you're taking two, but they're both great.
Okay, first of all, patients' awareness. And
patient awareness. I love it, and you're absolutely right. Neil, what would yours be?
I would be completely aligned with Professor De Somma there. I think clearly preventive education is the critical player here. I do think the patient's voice, people talk about technologies, absolutely technology is the way forward, but actually the most disruptive potential in healthcare, I think, actually is the patient's voice. If patients become activated and in the context of being empowered to take control of their health, this could be a game changer.
Right. And I'm going to ask Patricia and Winfried. You're walking along a beach, you kick the proverbial genie bottle with a genie in it. What would your one wish be? And I'm sorry, there are sirens in the background. I live quite near a very large hospital, and that unfortunately means someone's having a bad day. So I apologize for that. You go first, Patricia.
Free Netflix for all.
I've run out of good things to watch. Maybe you can make some recommendations.
No, seriously. I totally agree with Dr. Di Somma and Neil and Winfried. I think it's all about communication, and let's stay connected. We are partners in all this. And I think this equal relationship and shared decision making, that is for me very important.
Wonderful. Winfried?
I think I was a little afraid about this question. I think the last time I heard it was in a movie about beauty contests in the late 60s. The right answer was freedom. I would personally, I would like a little more pragmatism. It's a lot. A lot is easy if you just do it.
Lot to reflect on. Unfortunately, we've run out of time, and we don't have time for questions right now, and I'm sure there are some, but if you check the website, you'll see that you can post your questions there. And sadly, we have to wrap up now. I could actually talk to you lovely people all day, and although we've not had the pleasure of meeting in person, I hope I'll have the chance to do that very soon. And maybe we can do this again sometime when there's further information to share. And for those who want to share this with others, it'll be archived on the website where further information from our panelists will be there and their organizations will be listed in case you want to donate or learn more. I want to thank Servier again for their gracious sponsorship. Merci beaucoup. EMG for their very efficient stewardship and for keeping me in my box. And specifically, Kirsty and Mary, you're wonderful, and our amazing panel. And of course, you, our audience. So thank you for listening. Stay safe, stay well. Bye for now.
Bye.
Bye.
Bye. Bye.